my name is Peter Fecci. For those of you who don't know me, I'm one of the brain tumor surgeons at Duke, and I'm here to talk to you a bit about LITT, some of its indications, and some considerations for its use. Necessary disclosure slide. This is the basic, this is a neurosurgical tool, is intended for certain uses, can do harm if not used correctly, and of course, all brain surgeries do have risk. My own disclosures, perhaps not surprisingly, I do have a consulting agreement with Monteris. And a little bit of an outline to discuss what will come through in the presentation today. This is useful so that you can start to plan your naps. So what is LITT? For those of you not familiar with the technology, this will be a little bit of a definition of the technology and a bit of a display of how it is actually implemented. Importantly, some considerations. What are the things that you need to know about that might either cause you to push the pause button or at least allow you to consider whether this might be the right procedure for you? The LITT Fit, as I like to call it, is really where LITT fits in your oncology practice. So we'll talk about the variety of areas where it can be used and what the specific considerations for any particular disease state, such as glioblastoma, brain metastases, or radiation necrosis might be. Obviously, useful to have some data, so we'll provide some of that. Also, very important is to talk about how to interpret MRI images after the LITT procedure. There really is a unique course of imaging that you'll find after you perform the procedure. It's important to understand how those images should and could look. It's also important for your radiologist to understand the same. And important to that too, we've generated some of our own data that might be useful in objectively interpreting post-LITT imaging. Then at the very end, hopefully if there's time, can talk about some nanotechnologies and cool stuff like LITT in dogs, etc. So on to what is LITT. Admittedly, the idea of using heat in medicine is not new. However, the LITT technology is clearly a much newer rendition of that. And it's important to note then that LITT is exactly that. This is a thermal ablation technique. So although it uses a laser, the mechanism of kill is actually with heat. A little bit more detail here. LITT, of course, stands for laser-induced interstitial thermal therapy. Many people will just say laser interstitial thermal therapy. This is a minimally invasive surgical procedure. It's important to stress that this is a surgical procedure. It is an alternative to open craniotomy. It is not an alternative to other things like radiation, which is often used in conjunction with, much like one would use resection in conjunction with radiation. Typically, that incision is going to be under 1 centimeter. And then once that occurs, it's essentially the workflow of a stereotactic biopsy. There's a stereotactic introduction of a probe or a catheter with a laser diode at the end, and you can see a couple of those pictured on the right here. Maybe you can see my arrow, but you can see that there's two different types of lasers, particularly with the Monteris NeuroBlate system. There's a full fire that emits heat in 360 degrees, and then there's also one that's called the side fire, which pushes heat out exclusively, or at least more so, in one direction. This, of course, allows you to sculpt a lesion that's not spherical from the inside out. We always do perform a stereotactic biopsy at the outset of this procedure, and then we simply swap out the biopsy needle for the laser catheter. We then affix a robotic control to the laser catheter, which is introduced via a titanium bolt with the NeuroBlate system, and that's how it fixes it along its trajectory. And we can use that robotic control to control the depth and directionality of the laser catheter. There are multiple places you can perform the procedure. Once we do ours in an intraoperative MRI suite, others will often place this in an OR and then move to a diagnostic MRI. In either way, you'll be using MR thermometry or thermography in order to determine the zones of stun and kill, which is calculated by the software package. Patients do extremely well with this procedure and typically have a very short hospital stay. Oftentimes now we can even send patients home this next morning. We almost never place patients in the ICU unless there are other medical considerations. Worthy of note, there are 3 different possibilities currently for technologies. There's the Monteris NeuroBlate system, there's the Visualase system, which is Medtronic, and then ClearPoint also has their own system. The differences really here are in the directionality option of the NeuroBlate system with the side fire laser, the software and its interpretation of thermography, type of laser that's being used, as well as the cooling of that laser, and how the software calculates temperature. For full disclosure, I'll be just discussing the NeuroBlate system. So some key points off the bat. Number 1, LITT is a minimally invasive surgical technique. Again, it is not an alternative to radiation. It is an alternative to craniotomy for offering surgical cytoreduction. It is a surgical adjunct to those other types of therapies like radiation, much like craniotomy would be. And the strongest LITT programs really do represent a true collaboration between neurosurgery, radiation oncology, and medical oncology. So how do you use this technology, and what are some of the things that you need to consider? This is kind of a general schematic for current uses for LITT. As you can see, there are a variety of different tumor indications, including radiation necrosis. We'll lump that in with the tumor group. There's also a lot of uses in epilepsies, such as mesial temporal lobe sclerosis. This is actually a large use nationally. And then there are some other kind of miscellaneous uses, one or two of which we may discuss today. But I will really be focusing on the three arrows that you see here: glioma, radiation necrosis, and metastasis. So what are some of the problems here? Well, it's just like anything. Whenever you give someone a hammer, there's the old adage that everything starts to look like a nail. But the problem is that there really are some screws out there, and if you choose a hammer, you've got the wrong tool in your hand. Sometimes you really need a screwdriver. And LITT is the same way. It really isn't a panacea to be used in all instances of tumor, but there are some very specific uses when you choose the right tool. It has an outstanding indication and performs extremely well. So again, just to reiterate this hint, this is a surgical tool, and it's an alternative to craniotomy. So the key point here is saying, when am I going to use LITT as an alternative to craniotomy in the oncology setting? But what are some considerations for the procedure itself? First off, in general, with a single trajectory, you can generally treat lesions up to about 3 centimeters in diameter. You can consider 2 trajectories for lesions larger than that, but one must be aware of the fact that you're not removing the lesion and you're heating it in place and will cause some swelling. So you have to be in an area of the brain where you're willing to essentially accept that swelling. I think right frontal lobe is a really good, in right-handed individuals, is probably a good example of that. What's the extent of coverage that you need? There are some data out there to suggest that it very much mimics the situation with resection, i.e., once you start to cross about the 80% threshold, you will have a benefit. But of course, just like resection, maximal safe targeting is the goal. Heat is not specific for tumors, so that's why you need the surgeon there watching how the heat is behaving. You need to be able to stop heating in one direction if heat starts to go out into an eloquent area. However, you will note that lesions, and often necrotic lesions, do tend to heat more quickly than surrounding normal gray matter. You will cause some edema and some mass effect, as we mentioned, so you will need some steroids postoperatively. I often will do anywhere from a 4 to 8 day taper. I generally taper a little bit longer than craniotomy. Superficial lesions will provide some artifact for a couple of reasons. You have to use a titanium bolt that often will, if you screw too far down through the bone, will create some artifact when the patient's in the MRI being treated. You can place that bolt more superficially. Also, bone, dura, things like that can create some scatter artifact as well. So sometimes it's a little bit harder to see detailed thermography at the very surface of the brain. Other considerations are heat sinks. As you'll remember from your high school training, water has a very high specific heat, and therefore things containing fluid around your ablation zone may carry heat away. So what I call the rule of V's, ventricles and vessels, large arteries carrying blood away, ventricles filled with CSF can carry heat away. So you may find it difficult to get a fully ablative temperature bordering those lesions, but you'll still be able to cover well more than 95%. It's important to understand some of the nuances of trajectory planning, and of course, like any other technology, there's a learning curve for its use. One of the biggest problems, as always, as neurosurgeons, you've just given us a new toy. We're a kid in a candy shop, particularly when that toy is a shark with a frickin' laser beam attached to its head. And so when this was done early, I think people made some mistakes in its use, and that's why it's been really crucial to help define for the field where are the best, safest places to use the laser in the brain and what types of lesions might it be good for. So again, pushing the pause button. These are some of the things we've just discussed as at least considerations. Not all of these are contraindications. Periventricular lesions, you need to be aware that some of those areas immediately bordering CSF may be tough to kill. Superficial lesions, you may have some signal dropout at the most superficial parts and may have to wait to see heat come out on the other side of that dropout area to know that you fully encompass the areas surrounding that dropout. But there are techniques like placing the bolt in a more shallow setting here that really does tend to help with that. There are also new ceramic bolts that can help in addition. The position here on the right, or the picture here on the right, really is an absolute contraindication. Large lesion that would require multiple trajectories would cause quite a bit of swelling. It's near the brainstem. This is someone that you can see is herniating already. If you go and do this, you're really a good chance you're going to potentially kill this person. So these are scenarios where you really have to be aware that this is not the appropriate choice of modality. This is someone that needs a resection and resection only. As we think about where LITT might fit amidst our standard of care, it's important to think of some things that really are gold standards. And we're not talking about necessarily replacing those gold standards, but finding where some areas where the gold standards may not apply and where other things should be considerations. So what are the gold standards right now? Well, in GBM, the gold standard, of course, is surgical resection plus the Stoop regimen. Whereas in brain metastases, that's going to be upfront resection, or some people will actually do radiation prior to resection in cases when resection is indicated. And in essentially all instances, patients will get some form of radiation. Most often, SRS will be the most appropriate. So again, SRS plus or minus resection. So what are some of the areas where there's no gold standard? In GBM, it's going to be those patients that aren't eligible for Stoop. There's no gold standard for how to treat those folks. Who's that going to be? Well, it may be an elderly patient. It may be someone with a low KPS. And ultimately, that's going to prove to be at least about 30% of your practice. Of course, another area where there's no standard of care is in GBM recurrence, which of course occurs in essentially, but not exactly 100% of patients. There's further issues here in that an open resection may provide challenges due to poor wound healing, as well as a narrower therapeutic window, i.e. benefit versus risk, because these patients potentially may be more fragile, and there are challenges to the surgeries themselves in those instances, as well as additional scenarios where lesions may be difficult to resect because they're more deeply seated, but you can get a biopsy needle down there, which means you can get a laser catheter down there. In the metastatic arena, it's going to be patients who fail SRS. Again, no gold standard for how to treat those folks. It's essentially going to be 5 to 15% of your brain mets patients. They will suffer oftentimes poor wound healing if the scalp was in the radiation field as well, and therefore open resection for those folks can be a concern. Also, folks who have maxed out their radiation dose, what's going to be your move there? Radiation necrosis is yet another arena where I don't think there's a gold standard, and sometimes those patients have few viable options, and it may be about 10 to 15% of the patients that actually undergo radiation necrosis. You may be treating them with steroid. It may require long courses of steroids, and those medications, of course, have side effects as well. So that covers some of the considerations. Let's start talking about the specific uses here. The first place would be gliomas. We'll divide this into newly diagnosed and recurrent gliomas, and we'll begin with newly diagnosed GBM. Really, this is a pretty straightforward treatment algorithm. Maximal safe resection if able, and the Stoop protocol if able, which of course is a combination of temozolomide and radiation. But the key thing here is if able, and there are plenty of folks that you just can't do this full regimen of resection and Stoop, and you are going to need some way to provide those patients cytoreduction that's effective and permits subsequent therapy. And I think that goal of cytoreduction is also important to discuss. And to do that, we're going to go all the way back to the original Stoop regimen. So a lot of people here, a lot of you may have read this study many years ago and may not actually remember some of the details, which is understandable. The study is nearly 20 years old at this point. But I think people forget as a couple of important details. Number one, first off, there's essentially kind of a comparison group here of radiation plus temozolomide that was being compared to radiotherapy alone. And you can see a modest survival benefit, but that's really the survival benefit that you're providing with the Stoop regimen specifically. So the real question is there anyone in that original study that didn't get a benefit from the Stoop regimen? And the unfortunate answer is yes. So who are those folks? Number one, those were folks that got biopsy only. There was actually no additional benefit to the Stoop regimen over radiation alone if patients only underwent biopsy, and there was only a modest benefit in patients who underwent a partial cytoreduction with resection. There was also really no benefit to the Stoop regimen in patients that had a poor performance status, which also means that if you injure somebody with a resection, you also are leaving them essentially in a position to receive very little benefit from the standard of care therapy. So the key point here is that if you're only offering patients biopsy, you're really obviating the subsequent benefit of the standard of care. they really do need that cytoreduction. So when we think about that and we think about what the role for LITT might be in newly diagnosed GBM, let's look to those patients who don't get standard of care. So who doesn't get resection and maybe is only getting a biopsy or partial resection only? It's going to be patients who might have those difficult to access lesions, maybe a small thalamic GBM, who might not be eligible for resection and therefore don't get the benefit of cytoreduction. It might be, again, those elderly patients, patients with a low KPS, or patients with a suboptimal initial resection in an outside hospital that then are referred to you. What are you going to do with that residual tumor? Are you simply going to put them on standard of care with that residual? What if you could offer them a minimally invasive procedure to help cytoreduce that residual without having to reopen their prior craniotomy from perhaps just recently? And a key point here is that if you can get a biopsy needle into the lesion, you can often offer the patient cytoreduction via LITT. Biopsy patients who don't receive any cytoreduction, again, get no benefit from Stroop in the absence of that cytoreduction. So how prevalent in your practice is biopsy only, and how many of those patients might you be able to simply swap out that biopsy needle and get an effective cytoreduction with the laser? I think this is a great example of a possibility with a GBM. This is that deep-seated lesion that we were talking about, kind of bordering on the thalamus and internal capsule here. You can see the use of DTI here to define a variety of white matter tracts that you would not want to interrupt with an open resection. You can see the arcuate fasciculus here, see the corticospinal tracts, but you can also see that there's a really narrow window that you can thread the needle here, and that's the needle, that's the threading of the needle you would do with a biopsy needle to safely get in there to get a specimen. And again, you can simply swap out that biopsy needle for a laser catheter. This is a lesion that's small enough to easily be covered with a laser ablation, and you don't offer the risk of an open surgery in this patient, and yet give that patient the cytoreduction that they need. I think deep-seated low-grade gliomas are another great example. Here's a small low-grade thalamic glioma that you can see this T2 bright lesion here in a 13-year-old who presented essentially with signs and symptoms of some thalamic involvement. And this was one of the first cases of deep-seated glioma that I did. It went exceedingly well. We brought our functional neurosurgeons in and our pediatric neurosurgeons in to help plot a safe trajectory down to this. And we essentially took a DBS-style trajectory down to the lesion. He initially woke up with a little bit of weakness on that side, which of course made me very nervous. You do, of course, have to kind of cross perpendicular with the internal capsule to get there. But within a few days, he was doing fine. And he's kind of a funny, snarky kid. And so a few days later, when he was doing well at home at Christmas, he sent me this video.
Dr. Fecci, everything is working fine. Right hand still works very well. The left hand is doing perfect. This one won't go down. What? I don't get this. Thank you so much and a Merry Christmas.
So he's great, really funny kid, doing great now. It's years later, and he actually is enrolled in a combined undergraduate and medical school program at Brown University. Constantly sends me updates and knows fully that we use this video. He and his family love it. So some key points on newly diagnosed gliomas. Number one, if you're only offering biopsy, which may be 15 to 30% of your patients, you are obviating the benefit and survival benefit provided by the Stroop regimen. So what are you going to do for these folks? Who some of those folks might be? Patients with a difficult to access lesion, some elderly folks, potentially low KPS. If you can safely biopsy that lesion and it is small enough and in a safe enough place to laser it, you can frequently offer cytoreduction via LITT, and that cytoreduction is the goal of surgery. What about recurrent GBM? Well, we're moving on. We've covered newly diagnosed GBM. We're going to move into this realm here. This is a very easy area to find a large group of patients who don't have a standard of care. So again, 100% of GBMs essentially going to recur. What are you going to offer these folks? Are you offering them resection? Are you offering them Avastin, more chemotherapy, different chemotherapy, trials, more radiation, SRS? Hint, no standard of care here. And so that leaves us with a lot of room to try to figure out what the best thing for somebody is. And to drive this point home that I don't think there's really an accepted standard of care, this is a pragmatic algorithm that a friend of mine organized for us to show us the options in recurrent GBM. There are 1,000 of them. And if you ask 5 different surgeons or oncologists what they do for recurrent GBM, you'll get 10 different treatment algorithms. And the key point here is that thinking through some of these can be a real headache. But the fact of the matter is that most people will still believe that offering people more cytoreduction, if it can be done safely, is beneficial. And the fact is that really, if we're competing with resection and we're holding back on resection because of concerns of safety, this is really a great spot for a minimally invasive procedure. There's only about a 14% reoperation rate nationally for recurrent GBM. I think very often because it's that balance of the goals and risks of surgery. So that window is often narrower in these patients due to the increased risk of redo operations. What are those risks? Those patients have had external beam radiation therapy with scalp involvement. They're often going to have poor wound healing. And so that makes us very hesitant to reopen that surgical incision. They're often fragile themselves, having undergone a variety of treatments. They often will have their dura stuck to the cortical surface after radiation. It can be very challenging to get that dura safely off the surface of the brain. This is not a challenge that you have with the laser, of course. It may be very difficult to get lesions off of the surrounding scarred radiated white matter, and those borders may also not be clear, not an issue with LITT. They also may be on Avastin, which could preclude an open resection for a period of 4 to 6 weeks, and yet that tumor may be progressing if they're off therapy. You may need to wait much less to do a biopsy and LITT procedure. Evidence would seem to dictate that a week or 2 may be sufficient. The benefits of reoperation, they were clear in resection and reduction of mass effect, but from a biopsy perspective, where we get tissue, it can allow them to be included in tissue-based autologous trials. You may be able to sample that tissue for targetable mutations. And a lot of us really do believe, of course, that if you can safely offer these patients cytoreduction, there's clearly a benefit. And those data come from a variety of clinical trials, such as the one pictured on the right, where you can see that patients who had a complete resection, even when it was recurrent tumor, did better than those offered an incomplete resection on various clinical trials. Again, this is limited as it's retrospective data, but a lot of us believe that to be true. So what are the opportunities here? 100% of GBMs recur. All of these patients do not have a standard regimen and really deserve some shot at cytoreduction frequently if it can be done safely. Open surgery on these radiated scarred lesions is no fun. Most people are not getting resection, mostly because of the fear of risk of doing a big surgery in them. But what if you could do a smaller, minimally invasive procedure, get tissue that might help for trials, for targetable mutations, and offer those folks cytoreduction, which is probably helpful. There are some data out there in both newly diagnosed and recurrent GBM. I think the largest and best known paper of these is the one pictured here by John DeGroot out in San Francisco. And this was a study done in newly diagnosed and recurrent IDH wild-type glioblastoma. So these are folks, this is the worst of the worst, of course. These are the patients where anything you can do them to help is desirable. This is the largest to-date analysis of LITT in these folks, and there were nearly 90 total patients. And important to note that 43% of the newly diagnosed patients and 50% of the recurrent GBM patients had stable to improved KPS after LITT, with a very acceptable rate of adverse events, most of which, perhaps not surprisingly, were from transient edema and improved. These are some of the actual data themselves. The key takeaway here is that LITT really does have very comparable survival outcomes to those of traditional resection. If you look on the left side here, you'll see newly diagnosed disease. The overall survival in patients getting LITT plus subsequent standard of care was about 16 months in newly diagnosed IDH wild-type GBM with a progression-free survival of about a year. And that compares favorably to the numbers underneath that, which you see are the published outcomes in resection. And then the same is true for recurrent disease. If you look to the right, these are recurrent GBMs. LITT offers an overall survival of about 9 months, according to these data. Again, this is IDH wild type, so this is the worst of the worst, and a progression-free survival of about 5 months on average. And then, of course, that compares quite favorably to the overall survival numbers published for resection in recurrent disease. So this is safe, and it essentially compares quite nicely to the survival ranges obtained with standard resection. So some key points in recurrent GBM. Again, 100% of these tumors recur. There's no standard of care. Surgery is no fun. Many will usually get biopsied to establish their recurrence and to obtain tissue for testing. If you're doing that biopsy, you can very frequently offer cytoreduction via LITT in a concomitant time frame at that surgical time. And that is, again, the goal of surgery. Many will fear the risk of a big surgery in this population, although data suggests that there's continued benefit to cytoreduction if it can be accomplished safely, and LITT often can offer you just that. All right, we've covered gliomas. So the next branch of this will be talking about metastatic disease. Again, we harken back to our discussion of the standard of care in instances of newly diagnosed brain metastasis. All of these folks are going to get radiation. Most often, that's going to be stereotactic radiosurgery. Some patients are going to get surgical resection. Who are the patients that get surgical resection? And it's really important to think about this because we're basically saying that we're going to exchange surgical resection for LITT. So let's make sure that our goals of treating are the same. So factors favoring resection in upfront newly diagnosed brain metastases. Well, they've got to be stable for surgery, all that stuff. It's got to be accessible. In general, we're looking at solitary, a dominant lesion or oligometastatic disease. But really, the people that we're offering resection to in newly diagnosed metastatic disease are the people that we either need to reduce the mass effect from a large lesion to help alleviate their symptoms, or it's patients that we're taking out that large lesion because that's also going to help make subsequent radiotherapy more effective than the 85 to 90% local control rates that SRS already provides. And that is not the local control rate for EBRT and GBM, which is obviously considerably lower. So the key point here is that surgery, because SRS is so good, surgery in instances of newly diagnosed brain metastases is really being used to lower the mass effect or to help to reduce the size and volume of lesion to be treated with SRS to increase its efficacy. Well, if that's the reason we're using surgery, LITT becomes not the best choice. LITT is not the best way to treat large lesions that are causing mass effect. And in fact, in general, we want to treat lesions that are under 3 centimeters. And if we have lots amount of mass effect, that's really kind of a relative contraindication for using the laser. So my feeling is this is not the best application for LITT. In more than 200 cases of LITT, I have only done one newly diagnosed metastasis, and I'm not sure I would do that again now. The fact of the matter is that the patients not getting surgery are those getting SRS instead, which provides an 85 to 90% local control rate. SRS is the standard of care. Most surgically appropriate metastases are easily resected. If lesions are large or symptomatic enough to warrant surgery for mass effect prior to SRS, then LITT is not likely the appropriate surgical procedure regardless. If lesions are surgically inappropriate, i.e., you have a 2 centimeter lesion in the thalamus, they are very simply and effectively and non-invasively treated with SRS to the tune of an 85 to 90% local control rate. Why would you introduce the surgical risk even as low as it is with LITT when you can control that deep-seated disease with radiation instead? However, that calculus changes substantially when we move into the area of radiographically progressive metastatic disease after treatment, which of course includes both radiation necrosis and truly recurrent metastatic lesions. Radiation necrosis, let's talk about that first. This is where I began. That's going to be, again, about 10 to 15% of your SRS-treated lesions. Similar statistics for true failures and true recurrence, again, about 10 to 15%. As it turns out, radiation necrosis is going to usually be a delayed treatment effect, more than 6 months after treatment with radiation. People often ask, why are you treating dead tissue? It's not dead tissue. This is an inflammatory process, hence why all of your treatment options for the most part are anti-inflammatory in nature. I often will describe this to my patients here as a rash that develops in the brain after radiation that is nearly indistinguishable on imaging from true progression. I know there are a variety of techniques that people use out there, but nothing is 100% sensitive or specific, and biopsy does remain a gold standard. And so the beauty of also obtaining a biopsy is you obtain tissue that allows your medical oncologist to know whether there's been a real failure and they need to switch up a regimen. We also need to figure out whether we're going to need to offer more radiation after a surgical procedure. And ultimately, LITT, the beauty of it is that it is able to address either biopsy result effectively, whether that's radiation necrosis or truly progressive disease. So again, driving home the point regarding radiation necrosis, there are some common misnomers out there. So Rhode Island is not an island, although Long Island is. Acoustic neuromas are neither acoustic nor neuroma. They're vestibular schwannomas. And radiation necrosis is not just dead tissue. This is an active inflammatory process that causes leaky vasculature that allows in a host of inflammatory mediators. And what you're doing with the laser ablation is you're ablating those leaky vessels. At least that's the leading theory, and obviating this pathology. But it is, in fact, not just dead tissue, and the laser does really knock it out. We have plenty of data to show you to state that that's the case. But let's talk about how this fits into your typical algorithm now. So the typical algorithms for progressive disease and radiation necrosis are, well, let's talk about the initial treatment. Those patients have undergone SRS plus or minus resection, depending on what the lesion looked like. And now they're some months later, maybe even years later, and you see evidence of radiographic progression. How has that been handled traditionally? Very often, many people historically would just try steroids, and if steroids worked, they'd conclude that it's radiation necrosis, and if steroids didn't work, they would conclude that it is progressive disease. They might try imaging with things like perfusion imaging and draw conclusions from that. Many groups would actually do an early biopsy, and I would actually count our group in that group as a kind of standard for getting actual tissue that can be used to make treatment decisions. And unfortunately, there are those that will simply assume all radiographic progression is a failure and just re-radiate. The cure for a wasp sting is essentially never to have another wasp come and sting you in the same place. Same is true of radiation. More radiation to radiation necrosis can be devastating. And then unfortunately, those patients will get put on hospice rather than simply get an effective treatment that could have solved the problem for them. I will now say that at our institution, we have another option, which is early biopsy plus LITT. So we are now performing early biopsies because we get a definitive tissue diagnosis that informs our medical and radiation oncologists in a useful way. And then at the same sitting, we can very effectively treat either biopsy result with the laser. That has allowed us to move our biopsy actually earlier on in our treatment algorithms because we know that we have an effective treatment that can be used then and there, and because we get more information earlier on. So what are the LITT opportunities here? So for radiation necrosis and progressive disease, LITT addresses either diagnosis effectively and is a minimally invasive alternative to what can otherwise be challenging or annoying surgeries. It permits concomitant biopsy, which, as we talked about, provides tissue diagnosis that can be used to inform subsequent changes to either systemic or radiation therapies. And it also avoids you re-radiating a lesion that was simply radiation necrosis. What are some other important considerations here? Well, if you do LITT, you may find that you're able to get patients off of steroids much more quickly, and we'll show some data in that regard. Steroids have a wealth of side effects. We know that patients hate taking them for a variety of reasons, but one of the most important things to think about is that checkpoint blockade and immunotherapy has essentially become a standard of care for many solid tumors, including brain metastases from those solid tumors, melanoma and lung cancer being two of the most common here, of course. And if you have those patients on steroids, you are counteracting those immunotherapies. The faster you can get people off these steroids, the better. It can also allow you to avoid potentially using bevacizumab, which we mostly use as a salvage therapy in radiation necrosis, but some people use more frontline. But that bevacizumab, Avastin, also has a variety of side effects and may also preclude surgery. So there's a variety of reasons that it's advantageous to potentially avoid treatment with Bev as well. So how often do you see radiation necrosis? Well, we talk about this being about 10 to 15% of patients who are treated with SRS. We actually see it quite frequently. So this is a paper we put out about 7 years ago from Duke. We are in the process of now that we have many more patients that we've done LITT with, where we've obtained biopsy, we now have more than 200 such patients. So we will essentially publish an update to this. But from this paper about 7 years ago, at that time, we had about 35 biopsies that we had done for radiographic progression, where we definitively showed it was either local recurrence or pure radiation necrosis. And we found some interesting things. First off, if the radiographic progression occurs less than 9 months after radiation and you do a biopsy, it's about 50-50 split. But once you get outside 9 months following SRS, you start to see a real shift towards the diagnosis being almost overwhelmingly radiation necrosis. And these numbers may not hold true, but the key point here is the further out you are from radiation, the more likely it is to be radiation necrosis. And if people are going to fail radiation, they tend to fail it early. Overall, we tend to see somewhere around 60% of our biopsies for radiographic progression yield pure radiation necrosis. And this is a paper that we put out in conjunction with some folks at Cleveland Clinic as well, looking at the time to steroid independence after LITT. And found, again, with pretty good data, that doing LITT gets people off of steroids much more quickly than if you're just trying to manage radiation necrosis with steroids themselves. And you can see the data here, very significant, much more significantly quick quick wean off the steroids once you employ LITT. And you can see trends towards improved freedom from local progression as well as survival in these patients as well, though the study wasn't really being powered or wasn't really an endpoint that we were looking to obtain. That paper was published in 2022 in Neurosurgery, as you can see here. And this is another paper that's actually a larger series, also across multiple institutions, which we, of course, contributed to as well. One of the largest series looking at LITT for radiation necrosis, finding very comparable results, which is that patients get off steroids quite quickly following LITT, and then are also able to get back on their systemic therapies and have favorable outcomes with regards to symptom control, steroids, safety, and KPS over time. These are some of those data. And you can see that things like seizure prevalence are decreased. Patients get off steroids, in this case, at a median of about 13 days, and also had little to no interruption in their systemic therapy regimen. So a couple of papers out there really pointing to LITT being a very effective, safe, and useful procedure for radiation necrosis. This, again, is showing some more of the survival outcomes in that study. Median post-procedure overall survival was 2.5 years. And there was no significant difference and this is quite interesting, in those who got near total ablations and total ablations. If you got more than 90% out or cooked with the laser, basically you had equivalent outcomes. And most patients really didn't require any further treatment for the duration of their follow-up. One question I think many have asked is, if you use LITT for recurrent metastatic disease, do you need to come back in and offer further SRS? We had always done so because we were using LITT as an alternative to open resection. And in our particular institution, if an open resection found true recurrence of metastatic disease, we would always come back in with subsequent SRS. Not everyone does. And we found that some of our colleagues who were doing a lot of LITT were not necessarily re-radiating after LITT for recurrent metastatic disease. We asked the question in a retrospective nature, which of the data here are more convincing, and we combined all of our data sets across multiple institutions. This was Duke, WashU, Yale, Minnesota, and Cleveland Clinic. And so we were able to pool our data. Some were, again, treating, some not, and find that at least retrospectively, the data seemed pretty clear. So these had to be biopsy-proven recurrences. But when that was the case, we found that the combination of LITT plus a subsequent fractionated course of SRS, these were exclusively fractionated regimens, like usually 5.5 times 5. We saw that the combination group had a median freedom from local progression of approximately 30 months, which is outstanding, of course, in true recurrence. And that compared very favorably to certainly less than a year in either of the groups where those treatments were used alone for biopsy-proven recurrent disease. And overall survival was no different. Again, the combination producing median survival of more than a year, which is a complicated thing to look at in metastatic disease. Obviously, these patients have other lesions that are not being treated by the procedure, but still compared favorably and statistically significantly with either treatment modality alone. So some key points here overall for progressive metastatic disease and radiation necrosis. Again, LITT permits early diagnosis via biopsy, definitive diagnosis. It can address either of those biopsy results effectively. It's less challenging than an open surgery on radiated lesions and retains benefits for wound healing compared to craniotomy. And it can be a good alternative to prolonged steroid treatment or bevacizumab for radiation necrosis and can get these people off of steroids more quickly. I do want to discuss a couple of miscellaneous tumors, some additional oncologic uses that I think are important to consider as we're seeing more of these pop up and the experience with more of these pop up so that we can actually start to have some data. This was a patient that we treated at our institution that had a recurrent grade 2 sphenoid wing meningioma. These recurrent advanced grade meningiomas obviously can have somewhat limited treatment options, and the more the more you can offer them, the better they'll do here. So we're trying to not have to go back in with an open surgery here. The lesion was small enough in a location that we felt we could access it, and we had a very good coverage with the laser and offered a good surgical result. We're not the only ones with that idea, and we've contributed this case to a larger study looking at LITT for both new and recurrent meningioma. And this is many of these patients, of course, were going to be previously treated lesions, but this was both a prospective and retrospective case series. And you can see, obviously, that the overwhelming majority of these patients were recurrent meningiomas. I think you see a pattern where the laser is really useful in these recurrent diseases that have undergone prior surgeries. but there was experience with newly diagnosed patients here as well, and the outcomes were actually quite good. I think some additional uses here to consider are a subset of pediatric tumors, both of which we have experience with at our institution. On the left, you can see the tubers, the classic cortical tubers and subcortical tumors that may be part of tuberous sclerosis. They're often obviously a source of seizures, but they are often also very small and deep-seated, and LITT becomes an outstanding option to treat these tumors. Our pediatric neurosurgeons have a fairly decent experience with this here at Duke. And looking to the right, hypothalamic hamartomas. You can see the T2 bright lesion here, both in the coronal and the axial. I certainly have treated at least one young patient with gelastic seizures and a hypothalamic hamartoma. They left the hospital a few days later, now seizure-free after having had 8 to 9 seizures a day prior to that. This is a great use of the laser, deep-seated, difficult to access lesion, much less destructive, and can really, really reduce the seizure frequency in these kids, which can really be debilitating. So these are a couple of additional uses that people are really starting to put out in the literature. I should add that cavernous malformations, which are not quite tumors, but behave, I guess, somewhat like them, is an additional outstanding use. So as a summary, the LITT Fit. LITT fits well as a tool for surgical site reduction in instances where the therapeutic window for open resection is narrower, i.e. the risk versus benefit, but the desire for site reduction still exists. If you can biopsy, you can often safely LITT, barring the limitations of the procedure itself. And so let's go through the tumors. For newly diagnosed GBM, this is going to be deep or difficult to access lesions or fragile or elderly patients who might only be a biopsy or subtotal resection only. In recurrent GBM, LITT's going to be appropriate for basically all lesions, barring the limitations of the procedure itself, i.e., is it a large lesion that's not safe to treat? Newly diagnosed metastases, I think this is the toughest justification for LITT. Most lesions that don't need to be resected for mass effect are going to be very effectively treated with SRS instead. Recurrent metastases, again, all lesions, same thing with radiation necrosis. All lesions should be amenable to LITT, barring the size limitations of the lesion and limitations of the procedure itself, but these are all fantastic uses. So at the end of the day, as a total summary, recurrent lesions, radiation necrosis, and deep or difficult to access lesions that are less than 3 centimeters. This is really your wheelhouse for this procedure, and it does extremely, extremely well if you choose your patients correctly. And I think you can see evidence of that right here. So this is really the largest kind of registry of patients who've been treated with the LITT procedure for oncology nationwide. This was the Lantern registry, which was a prospective multi-center real-world outcomes registry, collected at the end of the day over 1,000 patients. And what you can see is that there are some real advantages to this procedure. Very safe, highly effective, little or no ICU stay. And again, keep in mind that this goes back to the very beginning of the procedure. Obviously, as people got more and more comfortable, people were getting pushed out of the hospital quicker and quicker, particularly during COVID. But even despite that, averaging it over the entire study, 33 hours median length of stay, over 80% of the patients going directly to home and not to something like a SNF or rehab, 1.8% 30-day readmission rate, and about a 5 to 7% complication rate, which is, of course, comparable to biopsy alone. Most patients reported an improvement or stabilization in their quality of life post-LITT, and that really showed better than a lot of the anticipated outcomes in this patient population, keeping in mind that most people who are getting LITT are people with recurrent disease and an otherwise short life expectancy. So really very favorable results with this procedure overall. As such, this has crept its way into the guidelines being offered by both the AANS-CNS from the joint section, as well as the NCCN guidelines, which now include this as indicated in recurrent metastases, radiation necrosis, and recurrent glioblastoma, where in patients who may otherwise be not outstanding open surgical candidates. But again, the AANS-CNS has also issued a position statement endorsing this in essentially similar scenarios, and not surprisingly, I'm an author on that statement, and of course, I'm an advocate in using this in the correct patient population. If you're going to go out there and start building a LITT program, I think it's important to remember a couple of things, and really that there's one group of friends out there you can't ignore. So the radiation oncologist sees 100% of new brain mets and treats 100% of recurrences and manages 100% of radiation necrosis, and incidentally sees nearly 100% of GBMs, just saying. Don't position this against radiation. It is used in conjunction with radiation, much like a resection is. This is something that serves your patients well as a combination therapy, and it behooves you to make friends with your radiation oncologist if you're going to build a successful program. Frankly, they will love you because you provide them a solution to radiation necrosis, to be very honest. We talked about the issues with imaging. Important to note that there's a very specific imaging course that one will expect to see after this procedure. This was the very first patient treated at Duke in 2015 with the laser for essentially radiation necrosis from non-small cell lung carcinoma. So this is radiographically progressive metastatic disease in an 80-year-old, and he lived for another 5 years after this. But you can see at the 2-month mark after the procedure, you get a slight expansion of the actual volume of the lesion, but a very thinning and eggshelling of that enhancement. And this is classic. So a slight expansion with an eggshell, enhancement, and then things start to contract down. So at 6 months, you start to see it get fuzzy, perhaps, and then you see it really contract down to a gliotic scar. Now at that 6-month mark, you start to get a little nervous, but you are seeing it contract down. You see the fuzzy enhancement, but it does really keep going down into that gliotic scar. So here's another patient, and you can see a very typical course as well. A month after the LITT, it's slightly expanded perhaps, but has a thin rim of enhancement. And then over the ensuing months, this time a little faster, you start to see it contract down into a gliotic scar. Yet another example, same thing. This one has a little bit larger volume expansion, but you get that thin enhancement. And again, over subsequent months, contracting down to a gliotic scar. Just to prove the point that you can do 2 lesions in one sitting, we did here 2 different trajectories, 2 different entry points. And again, both lesions with a very typical radiographic course. And by a year, really, these are just gliotic scars. Those were all metastatic disease and radiation necrosis. This was supplied by a colleague at Kettering, Dr. Newton, and shows that you can get similar type expansion in anaplastic astrocytoma, but again, seeing a contraction down to that gliotic scar over an extended period of time. As a case in point, you can see more rapid resolution. This is a patient that by 5 months, everything was essentially gone. I don't know what the instance is here and why this resolved so quickly. I have a mild suspicion that there was a little bit of a hemorrhage component to this lesion, just based on imaging, that may or may not have been a deciding factor. We have been trying to create some objective ways of quantifying this and evaluating this. And that paper I showed you that was in neurosurgery in 2022 earlier, looking at LITT for radiation necrosis, we actually then took those patients and decided, well, look, we see this enlargement of the lesion, but a thinning of the enhancement. So what if we just looked at the actual enhancement, the volume of enhancement, not the whole lesion, just the volume of enhancement? Might it actually not really be increasing because it's so thin, even if the lesion itself is enlarging? And we do see that actually that might not be a bad way of doing this. So at about 1 to 3 months after LITT, even that volume of enhancement can increase a little bit, but then you see that it really does start to contract down in patients that were then shown subsequently to have had a true response to LITT, whereas patients who then were found to have failed the procedure, often with tissue, you can see that they get an increase and they really never come down, and you continue to see a steady volume in that increasement over the ensuing months. So the key point here is that the data really parse out by about 4 to 9 months after the procedure. You can see that in that time frame here, in the responders, you're going to see a decrease in the volume of enhancement, whereas you're going to continue to see an increase in patients who fail the treatment. Our radiologists here have now started to develop AI regimens to kind of quantify this and have used it to try to divide patients up by that essentially volume to deconvolute them into essentially responders and non. And if we use that algorithm and separate people out into who we think are responders or not, and then look at how people did based on survival, you can see that we actually get a real parsing out of the survival and response to treatment. And so this does seem to be a fairly reliable means of parsing your response out. And just of note, this is a paper that just recently came out just in the last few months, actually, and is now actually out in Neuro-Oncology. Last part of this is that we talked a lot about retrospective data in this talk, a lot about looking back at patients with radiation necrosis and saying that they were able to get off steroids more quickly, looking at patients who had recurrent disease and who got laser plus subsequent SRS, and that they did better than patients who only got either of those alone. All of those data that we showed were retrospective, and there are inherent limitations to those data. So if we're going to get level 1 evidence for either of those conclusions, it really behooves us to go ahead and get some prospective randomized controlled data. And so enter the REMASTer study, which I'm the PI for nationally. This was initially piloted at Duke and Wake Forest. It is now opened up fully, and we have added Kettering Health. There are a variety of other institutions that will be signing on in the next few months. But this is basically a trial designed to get at some of those questions prospectively. So here's the design. Patients have radiographic progression of their metastatic disease. They're consented for the study. They undergo a biopsy. In the OR, we get a frozen diagnosis. If that frozen is radiation necrosis, then patients are immediately randomized to either medical management with steroids or to undergo LITT then and there. If instead the frozen shows progressive disease, then they do get LITT no matter what, and they're randomized to get postoperative period of observation or immediate, i.e. within the next few weeks, postoperative SRT, which is a fractionated regimen. Interestingly, you note here that there are no placebos. Everybody gets a treatment. This is essentially a timing study. Patients who fail medical therapy can get LITT or any other salvage therapy deemed important. Patients who fail a period of observation can then subsequently get SRS. And what we're really looking to see is it better to do these things upfront or in delayed or not at all fashion? The objectives are pretty standard. Basically, we're looking at things like freedom from local progression, steroid cessation, overall survival, and quality of life and cognition over time. Some fun stuff, some cool stuff that we said we would kind of leave some room for at the end. So we are doing some things with our biomedical engineers to employ nanotechnologies that have a way of both expanding LITT coverages and lowering the energy needed to do it, as well as creating specificity for tumor borders, which makes LITT both safer and able to cover larger lesions, and finding ways to then combine that with things like immunotherapy. This was a paper we just put out in Clinical Cancer Research last year, which shows that if we fill up a tumor phantom with these nanostars, we can get much larger areas of coverage. They act like little lightning rods, chain reactions that flash and set off the next nanostars that flash only over a short distance, so have a very short treatment effect, but can essentially act like dominoes, taking the heat all the way out to the margins. And you can see we can actually use those nanostars to sculpt heating margins here like we do with an hourglass-shaped lesion. And if we put nanostars on one side of a phantom, put a laser down the middle, you can see how much better you heat one side. Interestingly, these things will actually collect selectively in tumors. They behave almost like a contrast agent. And so we can put them in, get them selectively into a tumor, even if administered systemically, get the laser into those tumors, and get a very rapid and low energy propagation of the heat to create a specificity for tumor at the border and minimize damage to surrounding eloquent areas. These are mouse tumors. We really need larger tumors if we're going to take this into a preclinical model that's relevant to the patient scenario. Enter the next thing that we're doing. NC State is one of the top vet schools in the country down the road from us. Monteris and Brain Lab were kind enough to donate systems as part of a study to NC State, which makes it one of the only veterinary colleges in the world with stereotactic neurosurgical capacities and LITT capacities. We spent a year, the neurosurgeon there and myself, designing the capacity to do both stereotactic biopsies and LITT in dogs. You should know, if you don't, that brachycephalic breeds like boxers and bulldogs get gliomas at an alarmingly high rate spontaneously. 20% of boxers will develop a glioma in their lifetime. And so it's usually boxers and Frenchies, just based on what America buys, that we're treating. And we've now treated 5 or 6 dogs, and we plan to use these dogs as preclinical models for being able to test the Nanostar platform and hopefully develop some improved modifications to the technology. This was one of our very first happy customers on postoperative day 1. This is a Frenchie.
You ready?
And you can see that he did just fine after the procedure. All he wants to do is get to the grass to pee, and she won't quite let him, but he eventually gets there.
Okay.
But he did fantastically, and we've really worked out some of the kinks with this and have this really humming nicely in dogs. So if you're interested or have any dogs with gliomas that you'd like to volunteer for a clinical trial, please feel free to reach out. So welcome to the 21st century. We've been waiting for you. I think LITT is a great answer to a lot of the problems we've had in treating some very difficult to access or difficult to treat progressive lesions in both the primary and metastatic arena. Hopefully we've convinced you of that with this presentation. This is a virtual one, so unfortunately you can't ask me any live questions, but always happy to answer anything that's sent out virtually. Want to thank my group and all of our collaborators, and as well as Monteris whose contact information is here, of course, if you'd like to reach out, as is my email. So thank you so very much for your attention.